Good morning, everyone, and welcome to this, what I think is a very, very important hearing of the Human Services Committee, which I would now like to call to order. And first would ask everyone to rise for a Pledge of Allegiance to the flag. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. So again, welcome. And just a couple of ground rules before we get started. We are being filmed, and my understanding is that our PCN, Pennsylvania Cable Network, is airing this show live right now. And also, we have a pretty ambitious group of testifiers today. So what I thought I might do is let all the people testify first, and then if we have any time, we do have to be out of the room by 11 o'clock. If we have any time, and we will have time afterwards, if everybody could possibly stick around, then we're going to open it up for questions at the end of the testimony. We're scheduled to get done the testimony at 10, so that leaves almost an hour for questions and answers. And first, I might like to just open it up by allowing the members that are present today just to say hello and let you know where they're from. And maybe we can start off with Alex.
Good morning, everyone. Alex Charlton, 165th Legislative District, Delaware County.
Good morning. I'm Michael Kaur. I represent the 150th Legislative District in Montgomery County.
Hello, Rich Irvin, representing the 81st District, which covers all of Huntington County, part of Center County, and part of Mifflin County.
Mike Driscoll, Northeast Philadelphia.
Good morning, Perry Warren from Bucks County, representing Newtown, Yardley, and Lower Makefield and Morrisville.
Representative Cruz, 180th Legislative District in Philadelphia County.
And I'm Gene DiGirolamo, Republican Chairman from Bucks County in the 18th District. And before we call our first testifier up, I'd ask Representative Cruz, do you have any opening comments or statement?
No remarks, Mr. Chairman.
Okay. Thank you. And if I might, just for a couple of minutes, because I really think this is a really important issue. We have a few more members coming in, so I want to give them a chance first to say hello and let everybody know where they're from.
Good morning. Representative Chris Dush in Jefferson and Indiana counties.
Hi, I'm Representative Judy Ward from Blair County.
Tom Mert, Philadelphia, Montgomery County.
Okay, again, welcome. And I have some comments. This issue of Medicaid is very near and dear to my heart because through the years, I realize how important this is, the Pennsylvania and the families in Pennsylvania. And I think the hearing today is very timely because, as I understand it, down in Washington about 9:30, the United States Senate is about to roll out their version of a health care bill, the changes that they want to make under the Affordable Care Act. But what's important to me, and I think what's important for today's hearing, is what they're going to do to Medicaid with that bill. Not only the expanded Medicaid, which was part of the Affordable Care Act, but also the traditional Medicaid, which was not part of the Affordable Care Act. And it looks like they're taking, I don't even want to call it an opportunity, but they're taking this opportunity that they have to correct some of the problems as they see it under the Affordable Care Act to really devastate traditional Medicaid, not only here in Pennsylvania, but across the country. And if I could just to explain the traditional Medicaid and the expanded Medicaid, which was part of the Affordable Care Act, has insured here in Pennsylvania about 725,000 people, as I understand it, as of the last couple of weeks. And that population are people, for the most part, who are in the workforce, who are working their 40 hours a week or more, making minimum wage, $8, $10, $12 an hour, and have no health care at their point of employment. And the way it was supposed to work was the federal government covered for the first 3 years 100% of the cost. And in 2018, the states were supposed to start picking up a part of that cost till we reached 2020, when then the match would be 90% federal, 10% state, which would certainly be something that our state here in Pennsylvania would be able to afford. Separating that from the traditional Medicaid, which has been in place for well over 50 years in the United States of America. And as I look at the population that traditional Medicaid covers in Pennsylvania, it is over 2 million people. 1 million of those are children. The rest of the population are chronically ill adults, the disabled, seniors who are in need of nursing care, and poor women who are trying to take care of their children. These are our most vulnerable citizens. Now, as I look at the bill, and again, it's a moving target down in Washington, what they passed out of the House and what they are considering in the Senate bill. As I look at it, it would be nothing short of disastrous for people in Pennsylvania who are on expanded Medicaid and on traditional Medicaid. And I'll tell you why I view it as this. It looks like for the expanded Medicaid population, they are going to take away that 90-10 match in 2020 and make the state pay a much bigger share of that match. And I'll just speak for Pennsylvania, but I'm sure it's like after the rest of the states that have expanded Medicaid, it will be the end of the program, because we could not afford in Pennsylvania to pay any more than a 90-10 match. If it was 60-40, 70-30, 50-50, which I think they're talking about over time, we're done with expanded Medicaid here in Pennsylvania. That's the end of the program. With the traditional Medicaid, if they do what I think they're talking about doing, like putting caps on the amounts or block granting traditional Medicaid, and again, this has been in place for over 50 years, 52 years. If they take and do what I think they're going to be doing, it will be a disaster. I'm telling you, for our most vulnerable citizens. Half of the births in Pennsylvania and across this country are covered by Medicaid. 40% of children across this country, and similarly here in Pennsylvania, are covered by Medicaid. 2/3 of the people that are in nursing homes, 2/3 of our seniors and adults who are in nursing home, people who have Alzheimer's, people who have a stroke, they are covered by Medicaid. And I want to remind everybody that before they can get covered by Medicaid for nursing home care, they have to spend down all of their savings first. Poor women, and I mentioned this before, who are pregnant, most of them are covered by Medicaid and get the care that they need for themselves and for their baby through Medicaid. Disabled adults, disabled children. I mean, do we really want to hurt this population? Is this who we want to cut back on the number of people who are insured or the benefits package? Do we really want to cap or block grant this population? I mean, I realize that there's a federal deficit, and that's a problem. But do we really want to reduce the federal deficit on the backs of this population? I think we could find a better way to reduce the federal deficit than in cutting $800 billion, and that's what they're talking about, $800 billion out of traditional Medicaid over the next 10 years. And that's what I think that bill that they're talking about introducing is going to do in the Senate, cut back $800 billion. Our hospitals will be devastated because these people are going to show up in the emergency room and the hospitals are going to be forced to treat them anyway and are not going to get reimbursed. And I want to remind everybody that expanded Medicaid gave health insurance to at least half of our uninsured veterans here in Pennsylvania. And also, because of the infusion of $2.5 to $3 billion with expanded Medicaid, it created an additional 25 or 30,000 jobs in Pennsylvania, most of them in the healthcare industry. That's what's at stake here with Medicaid and cuts to the expanded Medicaid and the traditional Medicaid. And I'm sorry, I just don't think it's anything short of unconscionable that we're even talking about doing that. So with that, before I get in more trouble, I'm going to start the hearing with our first testimony, and I'm going to call up Lisa Allen, who is a Deputy Secretary, Office of Mental Assistance Programs in Pennsylvania's Department of Human Services. Lisa, welcome. I appreciate you being here, and you can begin whenever you're ready.
Thank you. And thank you so much for your comments, Chairman DiGirolamo. I think you laid out the scenario very eloquently in terms of what this means for the Medicaid program. Again, good morning, Chairman DiGirolamo and Chairman Cruz and committee members as well as staff. My name is Lisa Allen, and I am the Deputy Secretary in the Office of Medical Assistance Programs in the Department of Human Services. I want to thank you for the opportunity to provide us with the information on behalf of DHS regarding the implications of the proposal to repeal and replace the Affordable Care Act and what that repeal means for the Medicaid program here in Pennsylvania. In Pennsylvania, Medicaid provides coverage to over 2.8 million Pennsylvanians. This represents 22% of the Commonwealth's population. Medicaid provides preventative services like vaccines and well-child visits, along with cancer screenings and newborn screenings for our children. It provides life-saving treatments for chronic diseases such as cancer, liver disease, opioid addiction, and hepatitis C. It also provides services that help people with disabilities and seniors remain in their homes and communities. More specifically, the Medicaid program in Pennsylvania currently serves 1.2 million children, with 387,000 of those children between birth and age 5. Over 248,000 seniors over the age of 65, 565 individuals who receive outpatient mental health services, and 215 individuals with substance use disorder diagnoses. The Medicaid program also pays for over 55,000 individuals to receive services in nursing homes each month. In addition, the Medicaid program pays for $104.8 million in direct health and health-related services to children to assist them to participate in school, and also provides $29.9 million to school districts for administrative costs related to the provision of these services. You may know this as the School-Based Access Program. It provides significant funding for children in our school systems. As you are aware, the Affordable Care Act gave states the option to expand Medicaid eligibility for individuals 19 to 64 years of age up to 138% of the federal poverty level, an option that Governor Wolf pursued immediately upon entering office in 2015. As a result, more than 715,000 newly eligible Pennsylvanians now have access to health care coverage through our Health Choices Managed Care program. I will say that the number of individuals as of this week rose to around 716,000 individuals. It does fluctuate from week to week. This includes 124,000 individuals with substance use disorders who have gained access to medically necessary substance use treatment services. These services are critical given the current opioid crisis. Last year, 4,642 Pennsylvanians died of a drug-related overdose, an increase of 37% from the previous year. That's according to the current Drug Enforcement Administration's field offices. This equates to approximately 13 drug-related overdose deaths per day, up from 10 drug overdose deaths last year. That's 3 more individuals every day in Pennsylvania who are dying from an overdose death. Phasing out enhanced Medicaid funding would place Pennsylvania's progress in addressing the opioid crisis significantly at risk. In addition to providing health care coverage to more than the 715,000 newly eligible individuals through Medicaid, the Affordable Care Act also enabled 410,000 individuals to gain health care coverage through the marketplace. As a result of these 1.1 million Pennsylvanians gaining access to health care coverage, the Commonwealth's uninsurance rate decreased from 10.2% to 6.4% in 4 years. That is the lowest it has ever been and well below the national average of 9.1%. The uninsured rate for children also fell to an all-time low of 4.1%. The Medicaid expansion has had other significant and positive impacts on Pennsylvania, including a reduction in the amount of uncompensated care that general acute care hospitals saw in 1 year. It decreased by $92 million in 1 year. This was an 8.6% decrease in uncompensated care and was the first decrease since 2001. We've seen 4,422 more physicians, 601 more dentists, and 444 certified registered nurse practitioners enroll in the medical assistance program. These are unprecedented numbers. Generating an infusion of over $1.8 billion in direct healthcare spending into the Commonwealth in calendar year 2015, and the addition of 15,500 jobs in Pennsylvania in 1 year. The American Health Care Act, which was passed by the House of Representatives on May 4th, would significantly change the Medicaid provisions of the Affordable Care Act. As Chairman DiGirolamo mentioned, the Senate is to come out with their version of the bill later today. We have not seen that, but we understand that there will be some additional changes that will be proposed. The bill that was passed by the House modifies Medicaid expansion eligibility and the enhanced federal matching funds associated with the individuals covered under the expanded eligibility levels. As Chairman DiGirolamo mentioned, the impact on Pennsylvania will be significant. The reduction of the 90% federal match to provide health care to the expansion population that the American Health Care Act would provide only 52% federal matching funds. Given the Commonwealth's current revenue situation, this would be devastating. Providing state funds to offset the loss of federal funds is clearly not a realistic option for Pennsylvania. Consequently, if the House bill were enacted, the state would be forced to make difficult decisions about who to cover, what services will continue to be covered, and the rates that we will be able to pay to providers here in the Commonwealth. In addition to the phase-out of the expanded funding for the expansion population, the American Health Care Act also proposes a per capita cap rate for each of the following 5 eligibility groups effective with federal fiscal year 2020. Those groups include the elderly, blind or disabled individuals, children, low-income adults, and again, the expansion population. Unlike the current federal funding formula, which provides federal matching funds for Medicaid expenditures made on behalf of the state's federally approved Medicaid eligibility groups, the American Health Care Act would limit federal funding to the capped amount calculated, and would provide no additional federal funding for healthcare costs that exceed the calculated cap. Over the last 5 years, our average per capita growth in Medicaid has ranged from 2.2% to 5.3%, a trend that is expected to continue and which may not be supported by the per capita funding formula. States would be forced to make difficult decisions about what those services are that they can continue to cover. Our most recent estimate shows that Pennsylvania will lose over $2 billion per year in federal revenue as a result of both the reduced federal funding match for the expansion population and the shift to the per capita funding formula. Depending on what comes as part of the Senate bill, that could change significantly from what this estimate might look like. In addition, the President's recently proposed budget follows through on the American Health Care Act $800 billion cuts in Medicaid, resulting in 10 million people losing coverage, according to the Congressional Budget Office. I think Representative DiGirolamo laid out who those populations really are. They are our most vulnerable individuals. In addition to the reductions through the American Health Care Act, there are $610 billion in Medicaid reductions over the next decade proposed. The proposed funding formula for the traditional Medicaid program will significantly impact Pennsylvania's Medicaid program and Pennsylvania seniors and people with disabilities, who are among the most vulnerable that we serve. While seniors and people with disabilities represent approximately 30% of the Medicaid population and enrollment, the population accounts for 62% of Medicaid expenditures. Current population projections reported by the Center for Rural Pennsylvania suggest that the number of seniors will continue to increase. As a result, the current Medicaid per capita funding proposal would significantly underfund Pennsylvania's Medicaid program. Pennsylvanians rely upon Medicaid for their health care, and these reductions would be devastating to your constituents if implemented. Pennsylvania continues to evaluate what additional amounts will be included in the per capita calculation, what trends will be considered as part of those calculations as well. For instance, supplemental payments made to providers such as hospitals, nursing facilities, and safety net providers may not be included within the calculation. These funds provide additional support for Pennsylvania providers. In closing, the elimination of funding for Medicaid expansion would erase the gains that Pennsylvania has made over the past several years in ensuring improved health outcomes for our most vulnerable citizens. Jobs created as a result of the expansion will be lost, the uninsured rate will rise, uncompensated care rates for hospitals will significantly increase, and most importantly, over 715,000 individuals will lose health care coverage. The Department looks forward to continuing to partner with the Committee and the General Assembly as these proposals continue to be debated in Congress. Thank you for the opportunity to provide testimony this morning.
Thank you, Lisa, and I hope you could stick around for questions and answers. Me and you this morning could have switched places, I think, and it would have been fine.
Absolutely. Thank you.
Okay, thank you. Would like to recognize Representative McClinton's here and has joined us from Philadelphia. Representative, welcome. Next, we have Richard Edley. Up next, President and CEO for Rehabilitation and Community Providers Association of Pennsylvania. Richard, welcome.
Thank you. Good morning.
And you can begin whenever you're ready.
Okay, thank you. Again, my name is Richard Edley. I'm President and CEO of RCPA, the Rehabilitation and Community Providers Association. And we represent over 330 agencies and organizations throughout Pennsylvania, throughout the Commonwealth, in health and human services, serving well over 1 million individuals a year. And specifically, our members offer mental health, drug and alcohol, intellectual and developmental disabilities, medical rehabilitation, brain injury, long-term living, and other related services for children and adults in all settings. Now, I've submitted my testimony, so I won't be reading that, and what I'd like to do is hit some of the high points, especially since I think Lisa Allen probably stated a lot of the things that we all are, the sentiment and the statistics that we all share today. First, I do thank you for having this meeting here today. Obviously, as you said, it's a critical issue to all of us and those that we serve. And I'm actually in a somewhat unique position to be talking about this today because just last week I was in Washington meeting with several representatives as well as Senator Casey and Senator Toomey's office talking about all these issues and all these numbers. And I wish I had a good message for all of you today from those meetings, but what was clear to me from that was that the AHCA is real. It's a real threat, and it could and will likely happen. And what I was also told by several of the elected officials is don't count on a miracle, and it's time to begin the serious preparation. So again, I thank you all for having this meeting here today. What also came across in those meetings is how uniquely disadvantaged Pennsylvania is for AHCA compared to other states. We have sort of the worst of all worlds, or the best, depending on how you look at it, but we have a large rural demographic, a large population of elderly individuals compared to other states, a significant drug and alcohol issue, and heroin and opioid epidemic. Even though that's a national problem, clearly in Pennsylvania, we exceed a lot of the other states in statistics. We have a very high, although I will say appropriate, use of mental health and drug and alcohol services in the MA expansion. And we already have a robust managed care system in place, which has managed costs over many years. All of those things, which I'll get into my testimony, add up to even a worse AHCA outcome than some of the other states. I also provided, I believe you have, it was passed out to you, as part of my meetings in Washington, I signed a letter to Senators Casey and Toomey with about 26 other statewide associations and handed that to them, detailing some of these issues and detailing the problems and the Pennsylvania statistics. I provided that to you today. Also, I gave them a sort of a one-page front and back data sheet specific to Pennsylvania Medicaid and the impact that this would have. That was given to me by a national organization, the National Council. I thought it had some very interesting and good numbers, and I gave that to all of you as well today, so that's in your packet. A couple of things on just general perceptions of the public and, unfortunately, the elected officials that I met with last week. There's still widespread misconception that Medicaid is about health care for the able-bodied and poor. I heard that term so many times last week. Well, we're not about funding able-bodied people, and that's how people are viewing Medicaid. No one wants to talk about the populations you were referring to, Representative DiGirolamo, people with disabilities, mental illness, substance abuse disorders, brain injury, the elderly, children, and the many, many vulnerable populations. And if you believe that Medicaid is serving able-bodied individuals, you could only imagine what the perception is of Medicaid expansion and who that serves, and that misperception. You heard the numbers from Lisa Allen. Over 700,000 Pennsylvanians have enrolled in Medicaid expansion, and I'll give you some statistics as well about how many of those accessed needed mental health and drug and alcohol services. Also, what's being discussed with AHCA is, again, the use of block grants or per capita caps, and we're on record as being opposed to both. The reason is simple. Limiting federal Medicaid funds to Pennsylvanians will place the population served by our members at serious risk. The problem is simply that these methodologies develop payments based on historical costs. There's no way to rebase these projections based on any catastrophic or trends. And the trending moving forward is being talked about as things like CPI, CPI medical plus one, all very interesting, but does not have anything to do with the actual experience of what's needed to serve these individuals. I'll also tell you that for many years prior to being with the association, I was the CEO of a behavioral health managed care organization in the state. And a number of people have said, well, you were a CEO and you handled Health Choices dollars. You were just given a lump sum and had to manage it. Isn't that a block grant? Isn't that a per capita? Didn't you have to manage Health Choices just like that? And I want to point out the difference. The funds that we were given in Health Choices were based on an actuarially sound and certified analysis, which included proper trending. We also were allowed to express areas of concern and come back to the actuaries and say, you need to consider the following as we move forward in serving this population. And the goal of the program was always to manage the costs and manage services properly, but bring it down versus the trend. It was never about cutting services and rationing care. And make no mistake, that is what AHCA is, whether by design or as an unintended consequence of repealing and replacing ACA. To repeat the general message that we all know here today, that if these funds go away, we're all going to be in a collective position of figuring out how's the state going to possibly cover this, and we'll be in a very difficult position where vulnerable Pennsylvanians and those with disabilities will have to get in line and vie for this limited pot of money. A couple of other statistics. We can all argue about the budget here in Pennsylvania, but we know it's not good, and we all hear things like the $3 billion structural deficit and things like that. Well, again, if the proposed AHCA brings an additional $2 to $3 billion annual hit, what will that do? And also in the data that I gave Senators Casey and Toomey, there's a recent study that done by George Washington University Milken Institute of Public Health that stated that forget about everything we're talking about today in terms of serving individuals. If you just look at the economics of it, that they estimate that the repeal of the ACA in Pennsylvania will cost about 137,000 jobs right off the bat annually in Pennsylvania, related to healthcare and so forth. Another point I'd like to make is that we're talking about people receiving things like mental health and drug and alcohol services. If you do not serve this population, it doesn't just go away. And I think we all know that. And we've heard things like it will be uncompensated care, emergency room care, cost shifts to the physical health system, increased homelessness, increased incarcerations. There will be a cost. We're just taking the cost off the top line. What I wanted to then now do is just hit a couple of the specific populations that our members serve at RCPA in different population groups. First, intellectual and developmental disabilities. Right now, the Office of Developmental Programs spends about $3.5 billion a year with the federal match, and there are still unmet needs. While 55,000 Pennsylvanians are receiving some level of support from Office of Developmental Programs, I know some of you in this room also know there's about 13,000 on a wait list, of which about 4,000 are on an emergency wait list. If today, with this current funding and federal match, we still have 13,000 people unable to access needed services, what would possibly happen if AHCA comes into play? There's also some significant design shifts that Deputy Secretary Nancy Thaler has proposed, all of which are wonderful and we can support in terms of helping people with increased community participation and increased staffing to get people out into the community. How could that possibly be funded under these proposed changes? In terms of children's services, I think you heard before that 2.8 million are being served through Medicaid in Pennsylvania. 1.2 million of them are children. A reduction in this federal share will limit parent enrollment and would obviously have a negative impact on children with great needs, medically fragile, mental health needs, children with early intervention and special education needs. And then as we go to adult mental health, I mentioned before that with Medicaid expansion, more people have accessed care. We estimate about 160,000 new people were enrolled with Medicaid expansion with a mental health diagnosis. This means more recovery-oriented treatment, community care, and services that allow people to recover and live productively in the community. Without these funds, you will no doubt see less family-based support, less outpatient care, less inpatient care, a significant decrease in the ability to cover emergency and crisis intervention, and so forth. We know that with access to the right care at the right time, these individuals can and do recover from mental illness. We have to preserve access to and adequate funding for Medicaid for these individuals. And then substance abuse disorders. RCPA represents approximately 70 drug and alcohol agencies with about 170 facilities and locations throughout Pennsylvania. Medicaid expansion has literally been a lifesaver for many of the individuals these agencies serve. We've estimated about 97,000 Pennsylvanians have come into Medicaid expansion with a substance abuse disorder. Medicaid expansion has allowed these individuals to receive treatment for substance abuse disorders that they simply were not eligible for prior to Medicaid expansion. And then a final population I wanted to talk about, brain injury, individuals with brain injury, aging, and physical disabilities. It's estimated that next year 70,000 individuals with physical disabilities and elderly are projected to need Medicaid-funded services to help them live in the community rather than in costly institutional settings. That's just next year alone. So 70,000 people we would be funding to keep in the community rather than an institution. We also are expecting to get over $1.3 billion in federal funds to support these critical services in such programs as the proposed Community Health Choices, which is going to be implemented in January. If Pennsylvania receives less Medicaid funding from the federal government, wait lists for community services and aging and physical disability will clearly rise. People who need community appropriate settings will thereby be hampered in terms of being kept out of institutions and productive in the community. Many people with disabilities and seniors who rely on these services do not have family or supports that they can simply fall back on for their daily needs to protect them and their health and safety. So when we take this in whole, I think we're all saying the same thing, but I think I go back to my original statement, which was somewhat shocking, that in Washington, well, let me put it this way, we're sitting around the table listening to these numbers and getting it. I was surprised at how many people in Washington would listen to me and then simply fall back and say, but aren't we talking about the able-bodied? I'm thinking we're right back where we started. And so, again, the message that was given to me by many of the representatives and the senator, Senator Casey, was don't expect some magical solution. This is happening. We have to figure out in Pennsylvania, what are we going to do with this vulnerable population? How will we make sure services are preserved? How do we make sure people have access to services? And so I appreciate the committee looking at this very carefully and making some decisions, making some analysis of what this will actually mean. And certainly RCPA, and I know all the other people in the room today, stand ready to help you, the legislature and the General Assembly and the governor to do what's in the best interest for Pennsylvanians.
Okay. Richard, thank you, and I hope you can stick around. And I want to personally thank you and your members, your providers, for the absolutely amazing work that you do around the Commonwealth and providing services for our most vulnerable citizens. Thank you.
Thank you.
Next up, we have Antoinette Kraus, who's the director of Pennsylvania Health Access Network. Antoinette, welcome. Thank you for being here. And just to let the members know, I recently sent in an op-ed to some of the major newspapers, and I had Antoinette's help crafting that op-ed. It's in your packets. I put a copy in your packet, so if you want to read it after the meeting. And there's also some copies on the back table also, if anybody wants to pick up a copy of the op-ed that I just wrote on Medicaid and expanded Medicaid. So Antoinette, thank you very much. And
Thank you.
When you're ready, you can begin.
Yeah, and thank you for members of the committee for holding this hearing. It's very timely. I also am not going to read from my testimony. You have a copy of it. I have a couple new things I want to share today as we see Senate language coming forward this morning. But first, my name is Antoinette Kraus, and I'm the Executive Director of the Pennsylvania Health Access Network. We are the state's largest consumer-driven organization, making sure that individuals and their families have a voice in policy discussions at the local, state, and federal level. We also directly help connect individuals to health insurance coverage, Medicaid, Marketplace, and CHIP. And over the past 4 years, we've connected over 8,500 individuals to those vital programs. We also field about 8,000 additional calls to our helpline every year. We help folks in almost every county. We service 51 of 67 counties. So we help folks in urban populations, rural populations, small business owners, working individuals, parents who enroll their kids in Medicaid. So we are directly on the front lines of these important vital programs. Later this afternoon, we will be releasing new analysis about what the fiscal impact will be to Pennsylvania under per capita caps. And we actually have updated numbers. So the bill, we saw leaked information last night, that under the current proposal, it would actually make further cuts to Medicaid by rolling back CPI. So the American Health Care Act would have devastating consequences for Pennsylvania. It's estimated that roughly 825,000 people will lose coverage, more than half of those, 419,000, being individuals enrolled in Medicaid. Those losing Medicaid would include 125,000 children, close to 53,000 people with disabilities, and 48,000 seniors. This means that 1 in 2 people losing Medicaid coverage under the AHCA would be a child, senior, or person with a disability. Why are these cuts so severe to vulnerable populations? By 2025, Pennsylvania would lose $20.5 billion in federal funding to Medicaid through the AHCA's per capita caps. On average, the state would lose $3.4 billion a year from its Medicaid budgets in the years after 2020 when those caps start. Pennsylvania would simply be forced to cut Medicaid enrollment to make ends meet. And again, those are under the current AHCA proposals. Last night, we ran another analysis under the new proposal in the Senate, and I'll make sure members of the committee get a copy of this. It's estimated that it would cost Pennsylvania $29.1 billion by 2025, or $4.8 billion a year. Currently, Medicaid is a partnership between states and the federal government. The AHCA's per capita caps break the federal oversight that ensures the rules are followed. Under caps, states would be left to their own devices. Additionally, by creating inflexible limits, states would be unable to respond to natural disasters like Zika or the public health crises like the opioid epidemic. States would not get additional money to cover these costs and need to come up with the money themselves. Despite the fact that Medicaid spending has historically grown at a slower rate than Medicare, employer-sponsored insurance, and private health insurance, opponents of the program will argue that our Medicaid spending is out of control. That is not true. Between 2012 and 2014, Pennsylvanians' overall average annual growth rate in Medicaid was 3.9%. The current national average is 4.4%, while private insurance is 5.3%. Pennsylvania's Medicaid program is costly because of our state's size and aging population. Imposing unnaturally low limits on Medicaid spending will not fix anything. It will break a program that already works. Pennsylvania lacks resources to replace these lost federal funds. Losing a minimum of $3.4 billion per year would effectively double or triple our current budget deficit, with Pennsylvania taxpayers left holding the bag. The result is that over 225,000 children, seniors, and people with disabilities from the Medicaid program will lose coverage. Additionally, our successful Medicaid expansion would be in jeopardy, meaning Pennsylvania's uninsured rate would skyrocket, with people locked out of the care they need. Limits on federal funding imposed by per capita caps are artificial, unrealistic, and not aligned with the natural growth rate of healthcare costs. Pennsylvania cannot afford to lose $1 billion a year. So we have launched a campaign. It's called Insure PA. Last week, we submitted a letter to Senator Casey and Senator Toomey of over 142 organizations in Pennsylvania who would be impacted or concerned about cuts to Medicaid. In addition, we've received over 500 stories of folks that are worried about what changes in Washington would mean for those coverage. So, we like to talk about numbers and statistics, but I really want to share with folks two stories of individuals who have written us, because I think, they really emphasize what's at stake. So Al from Bryn Mawr wrote to us, "When I planned to become a parent 21 years ago, I never expected to rely on Medicaid. More importantly, I never expected to hear that our 6-month-old child had only a year to live due to a condition called spinal muscular atrophy, a rare incurable neuromuscular disease. Thankfully, that prediction turned out to be wrong. My son Jack is now 21, and in spite of his physical limitations and medical fragility, Jack is a happy, motivated, intelligent person who enjoys his life, his friends, and his family. To keep him healthy has been no small task over the years, however. My son is physically dependent on others because, except for some slight movement in his fingers and toes, spinal muscular atrophy has left Jack essentially a quadriplegic. He requires extensive care, including medical specialties, 24/7 nursing care, medical equipment like a wheelchair, a feeding tube, a ventilator, therapist, assistive technology, and occasional hospital stays. Jack receives all of this care through the Medicaid program, the very program that Congress voted to cut with the passage of the AHCA. Our family has been fortunate to have access to coverage we need to help Jack thrive despite the challenges he faces, and we're not the only ones. If Medicaid is cut, what will happen to those vulnerable children and their families? What will happen to Jack?" Another parent wrote to us, "Meet Anna from Hanover. In late 2008, when my children were 8 months and 3 years old, they were both diagnosed with a rare genetic disease called Noonan syndrome. NS is a genetic condition that affects multiple systems of the body. After the diagnosis, we were completely unprepared for how much our lives would change. 2009 was a whirlwind year. We went through many tests and multiple surgeries for both boys. Because my son's condition made it difficult to enroll them in a traditional child care setting, and because of the level of care they required, I was forced to quit work to care for them full time. Although my husband makes a good living and has medical insurance through his employer, we were stretched thin financially, and our copays and medical bills piled up. By 2010, we had accumulated $42,000 in debt. I found out that we qualified for Medicaid because of my children's diagnosis, despite my husband's income. Because we were drowning financially, we had no choice. The electric company was always threatening to shut off our electricity, and we had to have 3 yard sales a year just to make ends meet. We frequently had to choose between buying necessities like milk or bread and paying for a needed prescription. It just wasn't sustainable. Medicaid began covering the costs of my son's care that weren't covered by our insurance. We have been able to pay off the vast majority of our debt, and our family can go do normal things again, like eat out and go to the movies. We feel as though we have been able to rejoin society and have settled our debts on our own. My sons are doing much better now, but we never know what the future holds or what interventions may be needed. It's already hard enough to deal with this diagnosis, but at least now we don't have to worry about the financial aspect. We can simply focus our attention on what's best for them. I think we all can agree that no one law could have fixed our healthcare system. The Affordable Care Act is not and has never been perfect, but under that law, Pennsylvania's uninsured rate has dropped to an all-time low of 6.4%. With such a dramatic improvement in access to health insurance, we should be focusing on other factors such as reducing healthcare costs, improving quality, and making plans more affordable. Instead, if the AHCA becomes law, we will see our uninsured rate go beyond pre-ACA levels, while exacting devastating costs on our state's fiscal health. We must not go back so far as to force individuals to choose between the care they need and food on their table, or their home mortgage. This puts the lives of our loved ones on the line and is too great of a price to pay. Thank you for this opportunity to testify today. Thank you.
Next up, we have Lisa Davis, who is the Director and Outreach Associate Professor of Health Policy and Administration for Pennsylvania Baltimore Rural Health. Lisa, welcome.
Thank you very much. And thank you very much for the opportunity to be here to discuss the ways in which Medicaid expansion and the ACA and any changes to those programs will affect the health status of rural Pennsylvanians and also the facilities that provide that care. I provided my comments in the testimony that I believe is in your packet, so I'm not going to read through that. And I also am realizing that the other panelists provided very good information, and you, Mr. Chairman, also I think have a very strong understanding of Medicaid expansion and the ACA and what is in the AHCA. So I don't want to take time to repeat what I think many folks around the room already know, but do want to reinforce some points. So, Mr. Chairman and members of the staff, and also to Chairman Cruz, thank you very much for the opportunity to provide this testimony on the impact of health care reform and modifications to funding of the Medicaid program on rural Pennsylvania. As Mr. Chairman said, my name is Lisa Davis, and I'm the Director of the Pennsylvania Office of Rural Health. My office is one of 50 state offices of rural health in the nation, so there's one like us in every state. My office is located at Penn State, and we have been there since 1992. The purpose of the State Office of Rural Health program is to provide technical assistance, partnership development, and other types of support to healthcare facilities and to others who provide and who work to increase access to healthcare services in rural areas. And my office is dedicated to ensuring access to high-quality, affordable health care in rural areas and to enhancing the health status of rural Pennsylvanians. We have a large number of projects that we work with, but one area that I will be talking about and referencing in my comments is the work that we do with the state's smallest rural hospitals, most specifically the 15 critical access hospitals that are located throughout the Commonwealth. My office appreciates the focus on today's hearing and also appreciates the interest in the health care needs of rural Pennsylvanians. As you may know, Pennsylvania is considered to be one of the most rural states in the nation. And in fact, depending upon who's counting, we are number 3 in the country. Pennsylvanians living in rural communities are more likely to have unmet health needs and poorer access to health care than those in urban communities. Pennsylvania's rural residents are, on average, older and have lower levels of income compared to urban residents. Rural Pennsylvanians are more likely to defer care, suffer from more acute and chronic health conditions, due to higher out-of-pocket costs and a reduced ability to pay for services. And access to healthcare services in rural America and here in rural Pennsylvania is also an issue, especially considering that 2/3 of the primary care providers who practice in Pennsylvania practice in the 4 most urban counties, and that there are fewer hospitals that provide services to this population. There are about 42 acute care hospitals located in rural Pennsylvania, and as I said, 15 of those are federally designated as critical access hospitals. These hospitals serve a high proportion of Medicare and Medicaid patients and also provide high rates of uncompensated care. As was mentioned previously, under Medicaid expansion, which was a significant benefit to the uninsured here in Pennsylvania, more than 700,000 Pennsylvanians gained coverage, many of whom suffer from significant chronic conditions. During a recent period, approximately 1/3 of Medicaid expansion enrollees were diagnosed with and treated for substance abuse and/or mental health illness. Medicaid enrollment in 5 rural counties increased by at least 10%. With Medicaid expansion, the uninsured rate in Pennsylvania dropped significantly, representing a reduction of the uninsured by nearly 40%. Medicaid plays a critical role for Pennsylvanians who live in small towns and rural areas. And in fact, in some communities, Medicaid is of greater importance in these areas than in metropolitan areas. As was previously noted, almost half of all children living in small towns and rural areas receive their health coverage through Medicaid. The role of Medicaid in small towns and rural communities grew considerably in the past 7 years, contributing to a reduction in the total number of uninsured. One significant benefit of Medicaid expansion and the ACA in Pennsylvania has been realized by the state's 15 critical access hospitals. Hospitals with this designation receive 101% reimbursement for the inpatient and outpatient services they provide to Medicare beneficiaries. This was established by CMS about 20 years ago in recognition of the fact that these critical access hospitals serve such high numbers of Medicare and Medicaid patients and also high numbers of uncompensated care. In Pennsylvania, the state's critical access hospitals receive a supplemental payment from Medicaid in the following year based on cost reports that are submitted to the Pennsylvania Department of Human Services. That payment, or what we call the supplemental payment, fills the shortfall between the paid and full reimbursement for those Medicaid services. Historically, annual payments to the critical access hospitals have totaled about $15 million and can mean the difference between financial solvency and collapse. And I do just want to give you a short anecdotal story about that this year. Usually the payments for the Medicaid supplemental payment come out around the beginning of the year. This year they were delayed until April. And I heard from one of our critical access hospitals actually their bank called me, because the bank wanted confirmation from my office that the Medicaid supplemental payment was coming. This was in late January. The hospital had applied to the bank to get a bridge loan to be able to keep the doors open and to keep paying their payroll for those 3 months. So this supplemental payment is absolutely critical to these hospitals. This year, due to the increases in Medicaid enrollment, that amount increased to $21 million. Medicaid accounts for 15% of gross revenues in rural hospitals. Currently in Pennsylvania, there are 3 critical access hospitals that still provide obstetric care. So that is only 1/5 of all the critical access hospitals that still provide obstetric services. One of those hospitals is located 35 miles from any other like facility on Route 6. And if you've ever driven on Route 6, you know that it's not an easy road to traverse, especially in the wintertime. These hospitals that provide obstetric services receive an average of $2.8 million in supplemental amounts. Without that supplemental Medicaid payment, these hospitals would most likely be forced to no longer provide obstetric care. A critical access hospital study that was completed 3 years ago showed that over a 4-year period, 12 critical access hospitals in Pennsylvania had a total of 37 positive fiscal years, due in large part to the Medicaid supplemental funding. Without that funding, these hospitals would have had only 15 positive fiscal years, leading again to the potential for complete financial insolvency. Not only does this supplemental funding provide additional revenue for the hospitals, but has other benefits as well in lower numbers of uninsured patients, and as a result, a reduction in total uncompensated care provided, which in turn can lower the cost of insurance for employers. I have a number of other comments, but many of these have already been reflected by previous testimony that was provided. I do very much want to reinforce what the previous testifiers have said. The per capita spending for Pennsylvania does not work. The rollback of Medicaid expansion in Pennsylvania will have a serious detrimental effect in Pennsylvania in general and also across all of the rural communities. One of the issues, I think, with the AHCA and with any changes that might be proposed to Medicaid is that it does not take into account the special circumstances for special populations, including rural communities, where you have higher numbers of individuals who are on Medicaid or who are underinsured, and the special services that they need to protect them. And I think some of our previous panelists were very articulate about that. There have been a number of recommendations that have been made by both provider groups here in the state. We too were part of the large group that was pulled together that developed, I think, a very comprehensive, well thought out set of recommendations to our senators in Washington about the importance of maintaining many provisions of the ACA in Pennsylvania. But I would know that you would fully agree that it is essential that state and federal governments work together to ensure continuation of health care coverage for all residents of America, and especially for vulnerable populations. So I want to thank you so very much for your service to our state and for your very thoughtful consideration of these comments. It really has been an honor and a privilege to be asked to participate in this hearing and to provide this testimony on behalf of rural Pennsylvanians. And the Pennsylvania Office of Rural Health is very proud to represent rural Pennsylvania and those who provide high-quality health care, and we look very much forward to working with you and the other members of the General Assembly as we work to create a health care system that works for all of Pennsylvania. Thank you very much.
Lisa, thank you for your testimony. And like you, I am really worried about our hospitals. If something would happen, if they would pass one of them bills down in Washington. And just for the information of the members, before the expanded Medicaid, hospitals in Pennsylvania and around the country received what they call a DISH payment, which was called a disproportionate share payment, which would help hospitals, and literally for Pennsylvania, tens, I think hundreds of millions of dollars, which would help the hospitals pay for people who would show up and would have to treat them and they would not have any insurance. As part of the expanded Medicaid agreement and the Affordable Care Act, the hospitals gave up their DISH payments to get the expanded Medicaid. And so that's why I am doubly worried about our hospitals in rural, especially in rural Pennsylvania and in our inner cities. If we lose expanded Medicaid, I am really worried about some of them being forced to close. So Lisa, thank you for your testimony.
Thank you very much.
Much appreciated. Next up, we have Alyssa Schatz, who's Vice President of Advocacy of the Mental Health Partnership, and someone I have worked with very, very closely through the years, and Julie Snepp, who is a certified peer specialist and peer advocate. So welcome to the both of you.
Good morning.
You can begin whenever you're ready.
Good morning. I just want to take a moment to say thank you to Chairman DiGirolamo and to the committee for holding this hearing on this incredibly important topic. I think these local conversations and opportunities for public feedback are really important in this process, and so I really appreciate you all creating that opportunity for us. So good morning. My name is Alyssa Schatz. I'm the Vice President of Advocacy at Mental Health Partnerships. We were previously known as the Mental Health Association of Southeastern Pennsylvania. We were founded in 1951, and we have about 40 programs and services throughout southeastern Pennsylvania. We employ roughly 250 people and provide services to 7,500 people with mental health conditions and their families annually. We have, one of the things that makes us unique is that at MHP we have a unique emphasis on hiring people with lived experience of a mental health condition themselves. And because of this, we know that recovery is possible. And we see recovery every day in our work, and it's one of the things that I'm most grateful for. In addition to being Vice President of Advocacy at MHP, I am also a family member of several people living with mental health conditions and also substance use disorder. And so I just want to take a moment to say that I personally have seen and benefited as a family member from Medicaid. I have seen Medicaid save some of my loved ones' lives, and I've seen Medicaid help my loved ones to become well in recovery, working, married, building families, and no longer on Medicaid today because they don't need it because they're well. So I'm personally very grateful for the Medicaid program. We are very concerned at MHP about the current proposals both to phase out Medicaid expansion and also to impose a per capita cap, which would cut drastic amounts of funding, as you've already heard today, from our Medicaid program. And this is because Medicaid is the largest insurer of people with behavioral health conditions in the Commonwealth. And because it's the primary insurer of people with behavioral health conditions, it's also the largest funder of our behavioral health system in this Commonwealth. Medicaid helps people with mental health conditions to find recovery, to gain employment, to build families, and lead healthy lives in the community. And we've made great gains underneath Medicaid expansion in Pennsylvania. Since we expanded Medicaid here, we've had more than 720,000 people, it's probably even higher now, access Medicaid. And of those 720,000 people, roughly 18% have access substance use disorder treatment, and 22% have access mental health treatment. And those are really phenomenal numbers because we estimate that across the Commonwealth, it's somewhere between 1 in 4 and 1 in 5 Pennsylvanians have a mental health need in a given year. So the fact that we're seeing access rates come in right around where we want them is a really good sign, and it's something that we want to keep going. But imposing a per capita cap and phasing out Medicaid expansion would rob us of these gains, and it would also take us even further back from where we were prior to expansion. Federally, the Congressional Budget Office estimated that the American Health Care Act out of the House would cut $834 billion from Medicaid over 10 years. And in Pennsylvania, the Pennsylvania Health Funders Collaborative has estimated that that means we would lose $3.4 billion in the first year in 2020 alone. That's an enormous amount of money, and I don't envy your jobs trying to balance that budget with $3.4 billion less in federal funding. Over 10 years, the Bazelon Center for Mental Health Law has estimated that in Pennsylvania, it would mean the loss of $18 billion federal dollars. The per capita cap proposals have been developed based on the false assumption that the Medicaid program is too expensive and that we need to rein in costs. As my colleagues, including Antoinette, have mentioned already, this is bad logic. It's just not true. Medicaid is already quite cost effective with an overhead rate that is half that of the private market on average at 7%. That's very low overhead rate. It has per member costs that when you look at the specific populations are much lower than those per member costs would be on the private market. And it also has low provider reimbursement rates. Since it's already a cost-effective program, imposing a per capita cap would leave states with few options for funding cuts, essentially forcing states to reduce benefits. A blanket one-size-fits-all funding cut does nothing to address the real drivers of healthcare costs, and it harms people in the process. This leaves people with behavioral health conditions particularly vulnerable. Rather than imposing a blanket per capita cap, which is not a smart way to budget, we feel strongly that the federal government should look to models which have saved dollars while also improving access to care and quality of care. In Pennsylvania, our Medicaid program uses an innovative carve-out model for our behavioral health services, and it saved the Commonwealth more than $4 billion over the initial 10 years alone. That's quite an excellent savings, but it also managed to improve access to care, and it expanded people's options to the types of care that they could have. These are the kinds of innovative solutions that we should be looking at, not blanket proposals. So I appreciate you taking the time to listen to my concerns today. I encourage you to please join us in urging our federal legislators to oppose both the per capita caps and the phase out of Medicaid expansion. It's a bad choice for our Commonwealth. And now I am very excited to be joined by Julie, who is going to be sharing her Medicaid story today.
Good morning. I'm really honored to be here. Thank you so much for inviting me. I really appreciate it. It's my first time testifying in a long line of accomplishments, being in recovery from mental health challenges. So thanks, guys. I appreciate it. My name is Julie. I'm 57 years old. I'm a wife, a mother of 3 boys with mental health challenges, and a crack-addicted husband. I mother him too. I also am a veteran, formerly homeless, and suffering with mental health challenges. I am here today proud to tell you that I am in mental health recovery and have been for 5 years. I became a certified peer specialist, a RAP facilitator, public speaker, advocate, and the list goes on. I started and wasn't diagnosed until I was 38 years of age, when my children were having their extreme difficulties. I was in denial, didn't want to believe it, didn't want to hear it, thought it was just my kids, and it was me. It was hard. I only had one place to turn to, and that was Medicaid. I went to the crisis center, covered by a base service unit, diagnosed, hospitalized for a week, and set out into the world. It was difficult to find services. The traditional medical model makes it a little more difficult to access services, but Medicaid was able to help me do that. Now, the very programs that got me in this seat today are being threatened, and I take personal offense to that. Recovery is strong and growing. Without self-directed care and the work of recovery coaches and certified peer specialists, I would not be here today. And those are the very programs, ladies and gentlemen, that are going to be cut. People are being helped day after day after day with these programs. I was helped. I've been out of the hospital, while actually they call it hospital free, for almost 20 years. If it hadn't been for Medicaid and the programs that it paid for, I would have been in the hospital, could be once every 6 months. How much money did that save the federal government then? How much money did it save the state of Pennsylvania? To allow these programs to exist, go forward, and grow, and nurture other people, and nurture people like me, so we can recover. Without Medicaid, it would not have been possible. And frankly, please, as a veteran who fought for this government and this country so that people like me could get help, I am horrified and outraged that the federal government would even consider cutting money, cutting budgets, cutting programs for the very people who fought to keep them where they're at. You should all be offended. It's wrong. I have done webinars, national webinars. Well, actually, they're worldwide now, right? Can't just say that. I'm working right now with Boston University on self-directed care. I'm now what did they call me? A national spokesperson for self-directed care in a new brochure that was just brought out. I've done numerous newspaper articles. I've protested in front of senators' offices. I have actually sat down with many representatives and senators and spoke with them and shared my story. I've done keynote speeches. I've worked with the Housing Alliance of PA on homeless issues. I have spoke on the steps of the Rotunda right here 3 times. The proudest days of my life. My dad cried. I don't know what to tell you. But I'm here to tell you that community integration, self-directed care, certified peer specialists, and recovery coaches, and all of the programs that are in existence helped me get where I am today. And if it wasn't for Medicaid, those things would not have happened. Please, please do what you can. Numbers are great and statistics are great, but you know what? I'm a real person with a real story, and I'm here to tell you today that if those things hadn't existed, I'd be homeless on the streets, I'd be filling your hospital beds, I'd be draining your medication supply, and sitting in an office somewhere, smoking a cigarette and drinking a Coke and thinking life is just dandy and not going anywhere or doing anything. Believe me, these programs work and they can't be cut. Thank you very much for your time.
Okay.
Thank
you both of you, Julie, especially you, for that very powerful, compelling, and a lot of ways courageous testimony this morning.
Thank you.
Great job.
Thank you.
Okay. Our final testifier is Deb Beck, who was the president of the Drug and Alcohol Service Providers Organization of Pennsylvania, and someone else I have worked with very closely. And as I mentioned on the House floor last week, in the middle of this drug, opiate, heroin crisis that we have, Medicaid has been critically important because length of stay. I know Deb's going to mention that, because people do not get better with 7, 10, or 15 days of residential treatment, especially with heroin and opiates. You need 30, 60, 90 days of treatment, and Medicaid will pay for that. So critically important in fighting this opiate and drug epidemic. Deb, whenever you're ready.
I'm always amazed how come you all know that. But you know why you all know that is people come through your doors and tell you that. It just seems to be the policymakers nationally don't seem to know that. I look around and I see you. I know you're just subject to an information overload, this week. God bless you. I'm going to try to make it a little worse, of course. That's my job, to try to torture you. I'm going to stay down to a couple of simple statistics, only like 4. Number 1, 4,642 people are dead, the last count, in Pennsylvania from drug overdoses. 4,642. And excuse my manners. Thank you for having this hearing. You're standing in for Representative Cruz, Representative DiGirolamo. Thank you for just not letting go of this. It is imperative we don't let go of this. 4,642 people are dead. If you think about Harrisburg, the size of the city of Harrisburg, that's almost 10% of the population of the city of Harrisburg, for heaven's sakes. 4,642 are dead, and that's okay, I guess, on some levels. I've been asked to address the impact narrowly focused of these changes in Washington on the drug and alcohol problem. Just a few more stats. I think they were verified by the Department of Welfare a minute ago, Health and Human Services, excuse me. According to what the department, 2,220 people got coverage for drug and alcohol problem under Medicaid. 2,220, it's actually over that. Of that group, 127,000 were the Medicaid expansion group. 68,000 were for opiate problems directly. So if you need those numbers, they're not mine. They are the department's. The Affordable Care Act has within it essential benefits. Drug and alcohol is one of the 10. That's at risk. The plan that's being rolled out or has been rolled out this morning may well leave up to the states the selection of what is an essential benefit. Now we're talking about a stigmatized illness where people die in shame and stigma at home in their rooms or bury their children or leave the bodies of their dead loved ones in the morgue and don't bury the body. They are so exhausted and so embarrassed. We've got to have drug and alcohol as part of any essential benefit. It also could be written off as a pre-existing condition. The changes in Medicaid alone, Medicaid expansion, you already heard the numbers, has saved lives in this state, and we give credit to Tom Wolf for moving forward on Medicaid expansion. It was imperative. We've got to continue it. We're going to, well, I'm looking around at you. I know what's going to happen. The people are going to show up on your doorsteps. They're going to be in your doorsteps looking for help or in the emergency room, or you might as well reopen the jails. I want to be crystal clear about that. Thousands of Pennsylvanians are going to be denied care and are going to die or end up in prison or end up in your emergency rooms or on your doorstep begging for help. And I've been in the field since '71. I represent the Drug and Alcohol Service Providers Organization of Pennsylvania. We're in every district. We have programs, treatment, outpatient, inpatient. Also, Commonwealth Prevention Alliance and the Student Assistance Programs are part of us. We keep seeing us reinventing the same thing over and over again. We know how to address this problem. We just need to get with it, and we need desperately for there to be financial stability both at the state and local level. This constant chaos does not augur well for our ability to do our jobs. If you trim traditional Medicaid, same problem. The states choose for and against what's an essential benefit. Who are you going to choose? A mentally disabled child or drug and alcohol? It's kind of an interesting juxtaposition. I think it's just immoral to set up those kind of choices. We are in the midst of a raging epidemic in the state of Pennsylvania. Make no mistake about it. It is at your door. It's in your home. It's in your neighborhood. I want to pause for just a moment and say, but for you and the wisdom of passing the Narcan legislation a few years ago, many more would be dead. And straight up, but for the leadership of Gary Tennis, then Secretary of Drug and Alcohol, 3,500 more people would be added to this tally of death. 4,642 are dead. I think the proposals being made on the federal level are irresponsible. I'm going to be straight up. For drug and alcohol, maybe they're good for somebody. I'm going to try to stay in my lane here, Mr. Chairman. But for drug and alcohol, the proposals are outright irresponsible. I was working on this new cookbook, and my new cookbook is, how could I possibly make the epidemic in Pennsylvania worse? How could I do that? Well, the number one way would be to make the changes that are being proposed in Washington. Get rid of Medicaid expansion, cut back on Medicaid coverage for traditional. If you want to increase the overdose death rate, that's exactly what you should do. And our congressmen need to hear that. They need to hear that. This is going to drive up the epidemic. Now, most people with addictions don't commit crime. That might surprise you, but President Ford's wife, Betty Ford, was kind of typical. There was a lovely woman who was dying in her own house of an alcohol and prescription drug problem. We know about it because she chose to speak openly of it as part of her recovery. But of crime committed, over 70% of crime is committed by people with untreated addictions. So you're going to unleash an awful lot of folks on the streets of Pennsylvania in your communities without coverage for treatment. You're going to see a mass amount of those kind of petty crimes that disable and frighten whole neighborhoods. The overdose death rate is going to go up. We're going to have more funerals, more people. We are putting people's risks at life with this. I want to pay a little tribute first to you for Narcan and your leadership on that. Please don't destabilize the drug and alcohol system in Pennsylvania either, folks. But let's not get rid of Medicaid expansion. I also want to say we need to give thanks to our police. This year, you may hear this as a little untraditional, but in the drug and alcohol field, we're grateful to law enforcement who put their lives on the line every day on this issue. We are grateful to law enforcement. Law enforcement's been clear that without treatment, it's not the solution. And we're also grateful to Josh Shapiro's recent announcement to go after the prescription drug companies where there has been if they find there's been misleading advertisement. We need the law enforcement community to turn off the faucet. Please turn off the faucet. We cannot handle what we have coming in to our field at the moment. So I want to I'm going to be really quick here today because I know you're getting tired, but I'm going to end with some clips. And if any of you want any of these, I have them from all of your communities. Addiction claims 2 more lives, 4 children left alone at a home over the weekend. Chairman DiGirolamo told part of this story the other day. 7-year-old girl ends up taking care of 3 toddlers in the home. Here's the joke. Both of her parents, no joke, her parents are dead. She couldn't wake them. She said, I couldn't wake mommy and daddy. She finally told the bus driver. This little 7-year-old went to the curb, went to school, after having given a bottle to the baby, changed diapers, and there were 3 children left alone at home. Her parents were dead, but it's even worse. It went on for 4 days. This little girl was living with her dead parents. Anyway, that's thank God for the bus driver. A Richland woman dies of a heroin overdose with her 3-year-old son in the apartment. And what happened is they called to check on the family member and went in and found family member, the woman's dead, a 3-year-old child is still there. Fortunately, they saved the child. Cambria County, a man and a woman dead in their house, 5-month-old baby dead of starvation in the crib. They know the parents overdosed and died, and that baby was left to starve to death in a crib. This is all heroin and drug and alcohol. Another one, Bethlehem Township, kind of moving around the state. A baby, 9-month-old, screaming at the top of his lungs, and somebody finally heard him. And because they heard him, they were able to save the parents as well. 9-month-old baby. Here in Dauphin County, a 4-year-old girl here in Dauphin County went into McDonald's and led the McDonald's employees to her overdosed parents that were knocked out in a car. But for a 4-year-old, the responsibility these children have taken on. Philadelphia, you've seen the stuff from Philly, the hidden hellscape. More on that in a moment. I've been talking to funeral directors. Some of them now are stocking Narcan in the funeral parlors. Narcan, folks, because while they're busy burying the body, sometimes the friends of the person who died are there to grieve, and people go into overdose. So stocking Narcan in the funeral parlor. Here's a funeral parlor guy who wrote, he found 6 words scribbled in ink on the palm of an 18-year-old's hand that he was preparing for burial. Born a king, he had written on his hand, died a slave. The funeral director said, I think he knew he was going to die in that moment. The same funeral director, seeing classmates and friends now in caskets in his funeral parlor. And he quickly says, these are kids from great young people, young adults from great families. Imagine the post-traumatic stress for the funeral directors at this moment. We have coroner's offices are having to rent out extra places for bodies, folks. I'm taking you through this grisly tale because I think we're still in denial. We are not acting like we're subject to an epidemic, and it's time we do so. The coroners are having to rent space to store bodies. In one area, they got storage trucks outside, like frozen storage trucks to handle the bodies. Some places, the autopsies are not being completed all the way because there's too many bodies. So if you had a needle, they're going to make an assumption of what you died of. There's a Go Live fund being set up to handle the costs of burying bodies that were just left because the families were destroyed, exhausted, tired, and had no funding. I think West Virginia is reporting that their funds for indigent, running out of money for bury the overdose victims for indigents. The Florist Association right now is very concerned because they're not seeing normal requests for flowers. Some of them report having to be counselors to families in ways they have never been before. Don Sapatican, Philadelphia Inquirer, statewide, Pennsylvania, 37%, fatal overdoses up 37%. Harrisburg Patriot News, 24 hours, 10 dead. District Attorney David Freed, Cumberland County, asking for treatment beds. We got to do treatment beds. This one out of Halifax, Pennsylvania, for God's sake. If any of you know where Halifax, Pennsylvania is, it's a little tiny town upriver from here. Police say these kids this was a December article of last year, the kids were fed by their parents in September. 2 months. Kids ended up at Hershey Medical, totally starved, and they had to restore them. This is McPherson Square, for those of you in the Philadelphia area, Needle Park, heroin hellscape, lots of coverage there. And I guess I want to say to you, we've got to do the right thing here, folks. We cannot let these changes go through. I have called Senator Casey's office. I know where he stands. we also called to schedule a time to talk to Senator Toomey's office. I have not heard from him, or I was expecting to hear from staff. I know I'm just a person. But I want to end my comments. 4,642 are dead in the name of a 7-year-old toddler who in McKeesport, Pennsylvania, got herself dressed to go to school and took care of 3 little babies in the home. Let's deal with this issue, and let's start acting like it's an epidemic. I think we are not acting like it's an epidemic. Thank you for your time.
Okay, Deb, if I could ask you to just stay right where you're at and maybe ask Richard and Lisa and Alyssa and everybody who testified to come up in the front. I think this will make it a lot easier for questions. I think we have enough room there. Okay, and Richard, maybe you want to bring that other microphone over a little bit closer. Okay, terrific. So I'm going to open it up for questions, and before we do, just one last comment. And as we talk about it, Medicaid expanded and traditional Medicaid, and I know people are concerned about the costs, but from my experience, going through the years, almost, if not every family in Pennsylvania somehow will benefit from Medicaid during the course of their lifetime. Sometime they're going to be in a health crisis or some type of crisis, and they're going to reach out for Medicaid. And every family in Pennsylvania is going to benefit somehow from Medicaid. That's from my experience. Questions? Representative Dush.
Thank you, Chairman, and thank you to every one of the testifiers. I want to start off, first of all, Lisa, you were up at Penn State, and I know in speaking with Congressman Thompson, he's been working with the Trump administration on the rural health issues portion of the AHCA. I was wondering your input, what you had in discussing with him. You said you talked with congressmen and senators, but
we have had the opportunity to talk with Representative Thompson when we've been down in Washington, and actually just had lunch with one of his local folks the other day. And what we've tried to express is the ways in which Medicaid expansion and the ACA in general have had an impact on the 5th Congressional District, which is one of the largest congressional districts in the country, and encompasses a great deal of rural communities. So, our role cannot be can really just be to advocate and educate. But we've been able to give him some very good specific maps of his district that looking at the increase in Medicaid enrollment up to and then from the date of Medicaid expansion. And I would not be able to speculate on how he wants to internalize that information.
well, I know he was actively involved with several of the changes that occurred. In fact, that's why President Trump had him up there. But we need to be responsive, but we also need to be responsible. We understand that right now with the $20 trillion debt for the federal government and with the financial bankruptcy position we're facing right now, we're not too far behind Illinois. One of the things it was said earlier that government one-size-fits-all approaches don't work, and that's one of the advantages of having the block grant type programs is that it allows the innovation to happen at the local level. Specifically, I even look at a young man that I went to see him graduate from the Department of Corrections boot camp, who is now actively involved with a Celebrate Recovery. It's a number of churches of various denominations are actively involved with it, and he has done fantastic. He helps others as well as he's engaged to be married. But there are changes and there are ways to be innovative, some on volunteer levels, some on at the local level, but I see that most of the innovation that actually occurs does not occur at the federal government level. Particularly, you look at the changes that have happened with CMS. CMS keeps imposing more and more restrictions on all of these providers, whether the medical or healthcare community. And what I'd like to find out is some of the changes. Have you actively, any of you, actively been going to the federal government regarding those the CMS requirements? And I know that both the Trump administration and Congress are using the Congressional Review Act to try and lift a lot of those burdens off of you. What kind of impact or what kind of approach are you folks using to address those kinds of things that will actually help drive down those costs?
If I may, we've been trying to get rid of a really troublesome regulation for my 40 years in the field. There is it's really a complex issue, but it's a goofy CMS rule that they made worse by saying you can only stay and get federal match. They incentivize federal match in rehab only for 2 weeks, which is a huge step back for Pennsylvania. It's a silly rule. It's a rule says that if you're in a individualized licensed treatment program that has more than 16 beds, there can be no federal match. Well, that's crazy. Again, as Chairman DiGirolamo said at the beginning, the people with opiate addictions are going to need long-term rehab, and why the federal incentive isn't right, I don't know. We've done a lot of letter writing and campaigning in Washington. In fact, we're backing legislation that was introduced yesterday by Congressman Fitzpatrick that would actually do that legislatively. But it is something that President Trump could do as an administrative action. This went into effect way before he got there. We've been trying to get rid of this for 40 years and would have welcomed the change.
How far back does that go? Because actually, under the Congressional Review Act, if the regulation was not actually reported to Congress, the 60-day calendar, 60 legislative day calendar does not kick in. So if that was never officially reported to Congress, then the Trump administration and the Congress could actually get rid of that thing very quickly.
I'll yield to somebody who has a different thought. I think they made that deadline. However, nonetheless, this is something that President Trump could change as a matter of an executive order nonetheless. It would make a huge difference nationally and is a bureaucratic rule that has never made any sense.
Those are the kinds of things I'd be very happy to hear if you guys are. Thanks.
Can I just piggyback on that? The rule actually was part of the federal Medicaid managed care final rule that was passed last year in May. And the effective date of that particular provision, which said that states could not claim federal matching funds for Medicaid managed care expenditures for individuals in institutions for mental disease, which they have classified drug and alcohol to be included within that definition, cannot receive capitation payments cannot receive federal funds for capitation payments after the individual has been in the facility for more than 15 days. So for Pennsylvania, we have been covering many of the non-hospital residential services for both mental health and substance use disorders for many, many years. And the federal government was aware that we were doing that as part of a cost-effective alternative that was approved as part of our managed care waiver program in Pennsylvania. So this rule effectively changed how CMS viewed those in lieu of services at the federal level. And we've been advocating, along with many others, to try to see if CMS would remove that provision or at least delay it until there is more of an opportunity for states to review and have more dialogue on that.
If I could just circle back on something you said a little earlier. But first, I absolutely agree with what Deb and Lisa are saying. And we, too, are always meeting with state and federal officials talking about all the regulations and rules and the onerous administrative requirements and how that increases costs and decreases innovation. Absolutely. I want to talk about the block grant again just for a quick moment. As I said in my testimony, we're against it. But if you asked me, could it ever possibly work? I'll say something that's blasphemous for our association. Yes, it could. and it actually could lead to innovation. But I think that the misperception is, it goes back to what I said earlier about when I was managed in a managed care organization in the state and managed health choices. If I had to manage the counties line item by line item and was restricted in how we spent money, there would have been no innovation in the program. And to give you an example, we manage behavioral health in the capital area, 5 counties, and the counties themselves did a study that showed for 10 straight years, starting in 2001, we increased the number of people receiving care while saving the government state about $100 million against trend. You couldn't have achieved that if it was line item by line item. So in essence, it was a block grant. The difference was, though, it was properly funded from the beginning. It wasn't based on, all right, how much can we cut, and now here's the money to the states. That's one difference. The second, we were always allowed to say, even if it was after the year, to project out, here's some of the things that went wrong, so we need to adjust some of the numbers, and we worked with actuaries to come up with a better number for the second year. That's not in the proposal. And then just the general trending is clearly not enough to keep up with how we serve people. So it's really not, does a block grant work or not? That's a theoretical argument. It's as it's proposed, can it work? And I would say that there's no way, from what I'm seeing and reading and hearing from the legislators.
I just want to echo what Richard said. I think all of us here at the table are all for increased flexibility and anything that creates innovation and saves costs while improving quality of care. But I think history has taught us that despite the myth that's out there, cuts don't spur innovation. What actually happens, as Richard said, is it limits our ability to be flexible, because rather than looking and saying, well, we think that we can save this much with this innovative model and taking a chance, people are going to look at the budget and say, well, I guess this early intervention program can go, or I guess this prevention program can go. We can't cut from crisis use because we know that that's a high level of care people are going to need, and then more people wind up in crisis, more people wind up in higher levels of care because they couldn't get those early intervention services.
Thank you. I'll just close with, crises usually do spur innovation out of necessity. And having been on 4 different continents and seeing healthcare, in fact, both my children have National Health Service cards from over in Britain, which I would not let them use while they were going back to visit, because I know how poor that whole system works. What I would challenge you is that with the financial the financial situations that we are in, to use this as an opportunity to start, along with the ask for money, also come to them with innovations, things that can be done both with Congress and with us and with the administrations. We need, my district, our median family income dropped $1,100, and we're already half of the national average over the last 15 years. This opioid epidemic is something that is serious in my area. The increase in percentage of the elderly population is a serious issue in my district. That being said, those people that are earning less money are being asked to pay more, and that's hard to do. The nation as a whole took a cut in the median family income. It's coming back now, but we really have to be mindful of the fact that we don't want to increase the debt on our future generations. At the same time, we do need to take care of the people who are in desperate need. Thank you.
Representative Schlossberg.
Thank you, Chairman, and thank you all for some incredibly enlightening and horrifying testimony. I think I have come to the conclusion, the more I'm involved in politics and government, that one of the great problems that we have is a complete and total lack of empathy for people who aren't us. So that being said, I want to try to bring this home to the average American, maybe someone who isn't on Medicaid or Medicare, maybe someone who isn't currently in a crisis, and maybe someone who never will be. How will the AHCA affect the average American who isn't taking advantage of government health services right now?
I'm happy to take that. So, in addition to Medicaid, the AHCA has proposed rollbacks consumer protections, including the essential health benefits. So states would have the option to waive that. So things like drug and alcohol treatment, mental health treatment, substance use disorder treatment, and that'll apply to everyone, even folks with employer-sponsored coverage. So, I think we all heard the stories before the ACA of, folks who got diagnosed with cancer or, kids who were born prematurely who reached a lifetime limit by the time they were 2 years old and were left uninsurable and had to pay out of pocket. And the AHCA would send us back to that time. So yes, it makes drastic cuts to Medicaid. It rolls back, financial assistance for folks that need extra help with health insurance. But every single one of us that has employer-sponsored coverage is now at risk from being, one accident or illness or diagnosis away from financial catastrophe because we will no longer be protected.
I just want to add to that what Antoinette said. Even for folks who maintain their employer-sponsored insurance, like myself, our costs are also likely to go up because this bill, the House bill, was projected to leave 23 million more Americans uninsured. And we know that when people are uninsured, they don't stop getting sick. They wind up at the hospital, they need emergency care, they need crisis care. It's very expensive, and that increases our private insurance and premiums as well.
If I may, for drug and alcohol, 70% of people with addictions are not on the welfare system. They're in the workforce. So our folks are it's really important that we don't shake the tree in terms of insurance coverage. The people from insurance may have a refinement on this, but about a third of the people in Pennsylvania have an insurance policy that's an Act 106 benefit. It's a law you guys put in effect. That means they get drug and alcohol coverage, and it's pretty darn good. However, the next chunk is Medicaid, but we're not talking about Medicaid to be responsive to your question. But the rest of the people in the main, unless it's federal benefits, are self-insured. These are the mega companies, the big self-insured companies. They fall outside the purview in the main of the insurance department. Well, to qualify, to get their health plan to qualify, they have to do the essential benefits. The essential benefits under the ACA include drug and alcohol. It used to be the self-insured plans in the main covered it or they didn't, depending on the predilection of the employer. So I think we will see everybody ended up cost shifted back to the welfare side or the jails or the emergency rooms if that goes through. The ACA is not perfect. I think they should have amended it, but I think you don't destroy what you got. What you do is, in my book, you move it around to make it better. I think you're right.
If I might add to that, we would also potentially see a reduction in the number of health plans that would be available within service delivery areas, which means that there would be less competition, which leads to essentially higher prices, or to reduced benefits offered through those health plans. The majority of employers in rural Pennsylvania are small employers, which is either less than 100 or less than 50, depending upon who's defining small. Those employers are very challenged to be able to put together health insurance benefit packages for their employees that are comprehensive and affordable. So I think that is another way in which the general population that has employer-sponsored health insurance could be impacted. The other way, and this is getting to what some of my colleagues just said, is that if we are looking at higher numbers of people who are uninsured or underinsured, they will need care. Everybody needs health care. And although we have a wonderful community health center program across Pennsylvania with federally qualified health centers and rural health clinics, people still need to go to the hospital. So they will show up in the emergency room. The hospital is required to provide that care. If the hospital, especially small rural hospitals and urban hospitals that provide high numbers of uncompensated care, they will begin to see how this affecting their bottom line. They are going to need to pass that onto either their commercial insurers, or they're going to have to somehow absorb those costs. If they're not able to absorb those costs, and I can think of a couple hospitals here in Pennsylvania that would be hard-pressed to remain open. And so this is getting to be a long-winded answer, and I apologize, but everything's connected. The healthcare delivery system and healthcare services in any county, especially in a rural county, is one of the top three employers: government, education, and healthcare. If those small rural hospitals go out of business, the ripple effect of the unemployed in that community will be far and wide, as those unemployed individuals then are unable to invest into other goods and services. So I think it's a little hard to show a direct line from changes to Medicaid to those who are already insured, but they will in fact be impacted.
Can I just also add, the American Health Care Act didn't just focus on Medicaid. It also makes substantial changes to the private insurance market and the exchanges. So I think that, coupled with all of the things that we've heard today, creates additional pressures on all private insurers and their ability, both employers, to purchase that insurance and to make those markets stabilized.
Okay, thank you. Anybody else have questions? I could think of a lot that I've had, but maybe just a couple quick points, and just kind of following up on Representative Dush's testimony and questions about we need to be responsible with these dollars. And maybe Lisa Allen, the question for you, I mean, I've been up here quite a while, and we've taken cracks at waste, fraud, and abuse in the Medicaid program. And from my experience, I think Pennsylvania does a really, really good job of cracking down if there's any waste, fraud, and abuse. Can you just expand on that a little bit about?
So one of the areas, especially in the Medicaid program, and this is a result of some of the rules associated with the ACA, we were required to revalidate all providers in the program. And that effort was a monumental effort. We revalidated over 2,000 provider locations over the past year, which required us to do additional screening and checks for any provider who was in the program who may have been precluded from either the Medicare program, another state's Medicaid program. And so that allowed us to not only focus on the recipients, but also on the provider side of the house as well. So we have been probably one of the states that has gone through the exercise and has completed our work. We're being asked to actually share our experiences with other states, so we've come up with some innovative approaches to address that issue. In terms of what we do with our Bureau of Program Integrity and looking at both providers as well as recipients, we have a very strong program. I don't have the details on the data that I can share with you, but we work very closely with them from a Medicaid eligibility, a service side, as well as from our managed care programs. They're also looking at our managed care plans and what efforts they have to deter fraud and abuse. So in terms of innovation, I think some of the things that we have talked about previously, the services that we've developed over the years related to peer specialists, non-hospital residential services for drug and alcohol services, those were innovative approaches that Pennsylvania employed a number of years ago, that other states now have jumped on the bandwagon and have seen the benefits of those. So for us, the per capita cap becomes difficult because of some of the things that we have already been able to accomplish in Pennsylvania. We've had a very robust managed care program for 20 years. I think Richard mentioned this, which leaves us struggling. Now, we are moving forward with a managed long-term services and supports program for our seniors population, which will certainly, we hope, improve access and also help to control costs in the program. But I think those are some of the things that we've been trying over the years to be very innovative in our approach. And the flexibility at the federal level, I can say just in my experience, is based on the policy agendas really of where things stand at that point in time. So flexibility and what that means still remains to be seen in terms of the cuts in the dollars and the funding, but then what comes with that really in terms of flexibility, just to respond to the question.
Thank you very much. And one final question, because we're almost on. Representative Bush, go ahead, follow up.
Yes, I just want to reflect both on your question and Lisa's response. There is, when it comes to flexibility, one of the things I would love to see come out of the federal government on this thing is allowing a lot more flexibility to the insurance companies, because there's a program out there right now, it's called MediShare. It's a Christian provider network that provides insurance that actually the ACA has said qualifies, but it's about a third or less, it's less than a third of the cost of traditional coverage even under the ACA. I've got people in my district that couldn't afford the ACA plans but are going through MediShare, and it's the doctors that are participating in this thing don't have to jump through all those little checkboxes that the federal government requires, and all of you folks are stuck with as well. So those are the kinds of things. Get the regulations off of the backs of the people who are trying to have their boots on the ground and really trying to take care of things.
Okay. Just one final question. We've got about 5 minutes. And I realize there's nobody here from CCAP representing our counties around the state of Pennsylvania. And because this funding for people with mental health, drug and alcohol, children and youth, homelessness, I mean, we provide the counties a large sum of money every year, although to remind everybody, and I know you all remember this, in the previous administration there was a 10% cut to human service funding to the counties that amounted to about $80 million a year. So over the course of the last, I think, 6 years, that's close to $500 million that the counties have lost in human service funding. With the expanded Medicaid 2.5 years ago, and I've heard from many of our county commissioners that it has taken an enormous amount of pressure off of our counties, because if the people did not have expanded Medicaid, they would be at the doorsteps of our county courthouses looking for mental health services, drug and alcohol services, people with disabilities. I mean, if we lose this expanded Medicaid, and the counties have been doing a pretty good job right now keeping up. I mean, I know some of them have waiting lists, but if we lose this expanded Medicaid, that waiting list, I believe, and maybe you want to comment to this, I think will be out the door, and our counties will be overwhelmed with these poor people because there is a large population that just won't have insurance. So anybody want to just comment on that? If
Sure. I mean, we agree with you. It's like squeezing a balloon. Anybody who thinks you're going to get out of this is crazy. We're squeezing the balloon. If we cut it off here, it shows up somewhere else. The estimated cost of untreated addiction right now for the country is $428 billion. That's the federal government's number, not mine, and it's just the easy stuff to measure. $428 billion. So let's do the math for PA. We're about 5% of the population nationally. You back those numbers down, and you can see we're $20+ billion a year cost of untreated, just of the untreated addiction, not the other services here. There's no way. Squeeze the balloon, it shows up somewhere else.
Yeah. Richard?
I just wanted to leave everyone with just a slightly different slant on all this. Obviously, we're all here in a unified way painting a pretty dire picture. And I thank all of you for not saying, you're just saying the sky is falling again. And certainly when it comes to county block grant or a couple of years ago with the budget impasse, a lot of us were up here painting a dire picture about that. I wanted to point out what the difference is, because back when those things happened, a number of you would come to me and say, I know it's bad, but programs haven't really shut down. Seems like people are still getting care. And the reason a lot of that perception is out there is because the providers who I represent, under those circumstances, will do anything to keep programs alive and will do anything to keep people in service and to do things, whether it's uncompensated care, whether it's foregoing payments, but under the budget impasse, as bad as it was short term. The county block grant is 10%. Here we're talking about a structural change where 50% of the funding can be gone. And what happens is that, yes, can a provider find ways through grants and foundations and other things to keep a program alive? It's no different than when you're talking about your own constituents. If someone is eking by and paying their mortgage and you say, you know what, your salary is going down 10%. I don't know, maybe they can keep their home. Maybe they'd find a way and get a second job, do something. But if you say, your salary is going down 50%, they will lose their home. So, while I hate to be up here saying this is it for real, I can't see how these kinds of changes under AHCA that the providers I represent will just keep things going. And going back to your question earlier, Representative, these providers are, yes, there are certain programs that are 100% Medicaid funded. There are IDD group homes and so forth. But most of these programs serve commercial clients, county people, others, so that if a program has to close, it's not just, well, I guess the Medicaid expansion people don't get that service. It's the entire community doesn't get that service, like crisis intervention and so forth.
And I'd just like to say to Richard's comment that if you are looking for the providers who did lose programs, I can tell you that we were one of them following those human service block grant cuts. We shut down, I believe it was 4 or 5 programs and laid off 20 to 25 employees following those cuts, and had to obviously reduce many services as a result. And as Richard said, that's just a fraction of a percentage of what this kind of a cut would mean for our Commonwealth. So.
Okay. Thank you. Thank you all for your terrific testimony today. I think we got to all work together. We're going to all leave here, and we're going to turn our computers on, and we're going to take a look at what's in that health care bill, because that came out at 9:30. And I know many of you said you've met with our congressional delegation. Some of you have met with our United States senators. I know Senator Casey this morning has already come out and said that he's opposed to the bill. I guess he must have, got a little bit of a heads up. I myself have had a conversation with Senator Toomey about a month ago, a very long conversation, and talked about a lot what I talked about this morning about how important this is. So I'm very anxious to see, because I know he had a lot to say about what is in that health care bill. He was one of the working groups. And if we get something we don't like, we just got to mobilize and just maybe we can make changes in it. And if we can't make changes in it, I'm going to be right in the front line of trying to make sure it doesn't get passed. It's just too important to our most vulnerable citizens. So again, thank you all for being here. And I'd like to, this meeting of the Human Service Committee is now adjourned. Thank you.